Welcome, everyone. Today we have the privilege of talking with a remarkable investigator who's just published a great study in JACC on sex differences from the STEP-HF study. Dr. Verma, thank you very much for joining us today. I wonder if you could just tell us a little bit about this paper and why is it such a big deal?
Well, thank you, Dr. Krumholz. Really, my great pleasure to be here. And thank you so much to JACC for accepting our paper and featuring this important sub-analyses. So this was a pre-specified sub-analyses from the STEP-HFpEF program. As you know, this is a program of two trials, the STEP-HFpEF and STEP-HFpEF-DM. We enrolled people with the obesity-related phenotype of heart failure and a preserved ejection fraction with and without diabetes. And this was a pooled analysis of the two trials of 1,145 subjects with obesity-related heart failure and a preserved ejection fraction. And we evaluated the efficacy and safety outcomes by sex in the trial. Now, why did we do this analysis? For several reasons. One, sex is a very important issue that really has implications across the entire spectrum of heart failure, and specifically heart failure with preserved ejection fraction. Sex influences risk factors, it influences pathophysiology, natural history, and prognosis of people with heart failure and a preserved ejection fraction. In addition to that, we've learned from the HFpEF literature in the past that sex is also a determinant of pharmacological efficacy of various therapies and therapeutic strategies. Now, when it comes to GLP-1 RAs in particular, we've learned from the diabetes literature and from the trials that have been done in people living with overweight and obesity that females tend to lose a greater amount of weight with GLP-1 RAs compared to male subjects enrolled in trials. So for all of these reasons, one, knowing how sex plays an important role across sort of the entire spectrum of HFpEF, and two, that GLP-1 RAs have differential effects in males and females with respect to weight, we thought it would be critically important to understand this phenotype. And it turns out that most of our prior understanding of how sex interacts with HFpEF has really come from trials that have not been dedicated to the obesity-related phenotype per se. So this is one of the first trials to carefully evaluate baseline characteristics, baseline features, clinical outcomes in an obesity-related HFpEF phenotype.
One of the most important things is that this isn't just a pro forma analysis, but there's a really great rationale for why we should be looking at sex differences here. And you are showing women lose more weight, they get the same amount of benefit. It's really indicating, don't you think, that these drugs are not just about weight loss, but also about disease modification of the heart failure with preserved systolic function?
I couldn't agree more. And as I've said, I think in the past, the story of semaglutide, at the heart of semaglutide is much more than weight. And what do I mean by that is that the heart benefits and the cardiorenal benefits may be partly related to reductions in weight, but cannot be explained entirely by weight reduction. And as you nicely pointed out in our analyses from STEP-HFpEF, the fact that females lose more weight but have the same benefit, is consistent with that hypothesis. Likewise, in people living with diabetes, we've also seen that people with diabetes tend to lose less weight compared to people without diabetes, but yet they have the same benefit. And other GLP-1 RAs that have been tested in people with diabetes that offer cardiovascular benefit actually do that in the face of actually very small reductions in body weight. So I don't think body weight reductions are the sort of dominant, are the only or sole mechanism through how these drugs work. But one thing that I think was really important here was us understanding the baseline characteristics of females versus males with obesity-related HFpEF. This has not been carefully defined before, and we can't really get a lot of insights from that from sub-analyses of other HFpEF trials per se. So what we found here is quite interesting. One, that females with HFpEF and obesity actually have a much higher baseline burden of symptoms and physical limitations. That's an important message for all of us as doctors to realize, that they bear a disproportionate burden of symptoms relative to males. Number two is that there's more inflammation. This has also not been described before, that in females with obesity-related HFpEF relative to their male counterparts, there's more inflammation. Three, the BMI is higher in females compared to males. And this goes back to this whole concept that females have greater visceral adiposity that may be at the root and the genesis of HFpEF in this population. And four, my last sort of comment about baseline characteristics is that all of the prior HFpEF trials have shown that females are older compared to males with HFpEF. And we found no such age difference in this analysis. And that is a really important message, because we think that people living with obesity-related HFpEF are about a decade ahead in terms of their disease progression, and that sex-related advantage, if I may, seems to have been lost in females with obesity-related HFpEF. And so there are some subtle differences in clinical presentation and baseline characteristics in this population that I think are quite worthy, and our clinicians who are taking care of these patients in the trenches, will appreciate that as they're seeing people and treating this disease moving forward.
Great. What's the most important take home for clinicians reading these papers? What should they remember about this paper as they go out and take care of patients on the wards?
HFpEF is highly prevalent, is more prevalent in females. We know that. In the STEP-HFpEF program, about half of the patients with obesity-related HFpEF were female. Females with obesity-related HFpEF are much more symptomatic, have lower KCCQ clinical summary scores, have lower 6-minute walking distance or exercise capacity compared to their male counterparts. They have more baseline inflammation. They lose more weight compared to males with semaglutide, 2.4 milligrams over 52 weeks, and they derive similar improvements, of a magnitude that is quite large, both in males and females, but similar magnitude to males with respect to KCCQ, 6-minute walking distance, reduction in CRP, exercise capacity, inflammation reduction. So at the end of the day, when the rubber hits the road, this is, as I say, this is a formidable strategy in a disease that remains recalcitrant, for which we have limited, options and solutions. And, I really hope that both patients and providers can really look at these data favorably and affect change for the future for their patients.
Dr. Verma, thank you for your valuable insights. You're truly an international leader in this field. You are making immense contributions, you and your team, and are making a big difference for patients. We're proud to publish your work in JACC and look forward to more breakthroughs, more information that will help guide therapy in the future. And we thank you for your time and contributions.
And thank you to you for your leadership, and to the entire staff at JACC for being so collegial and so kind and so cooperative throughout this journey with us.
Thank you.